Hello, and welcome back to part 2 of the chapter on gastrointestinal tract. We had left off at the colon, and we are picking up with things that go wrong with the disorders. I'm in the interest of keeping this not too long. I'm going to end up stopping in a weird place, but this way we can have 2 shorter sections. All right, so let's go with the disorders. We'll start at the top with the esophagus. One of the biggest things that we run into in the clinical setting is gastroesophageal reflux disease, or GERD. The problem here is that the lower esophageal sphincter, that is at the bottom end of the esophagus, this doesn't close adequately for the amount of pressure that's going on in here. And so the stomach, which is very well protected against the very low pH that's here, unfortunately, some of the fluid that's in the stomach leaks up into the esophagus that is not prepared. And it starts having an impact on the tissues here of the esophagus. And so the acidic stomach contents don't successfully stay down in the stomach. Things that contribute to this problem are anything that's going to increase the pressure on the stomach, like lying down after eating, Valsalva maneuver, that's the pressing down or bearing down. Just obesity, having extra weight of the abdomen that's going to be pressing down on the stomach. Pregnancy, when there's something inhabiting the uterus, it presses up on the stomach, and that so often our pregnant patients suffer from this reflux. The problem is this can damage the tissues here. It can lead to a stenosis. It can lead to obstruction of the food passing through because of this difficulty, because of the chronic inflammation. In extreme cases, it can lead to esophageal cancers, adenocarcinoma that results from here, secondary to GERD. And then what we get is dysplasia. If you'll remember way back when we were talking about cells and what happens there. Remember, dysplasia is growth of cells that are not quite right. They're not being quite right. So here, we would ordinarily have a certain kind of epithelial tissue. And instead of looking like epithelial tissue from an esophagus, it starts looking like epithelial tissue from an intestine, which sounds like a great thing. The body's trying. I mean, it's trying to accommodate, I guess, you want this acidic, I guess we'll try to deal with that. But it's not good. It's a short-term solution, but it indicates that there's damage happening to this tissue. And that damage, so when you get that dysplasia, it's referred to as Barrett esophagus, and it can be a precursor to the development of an esophageal cancer. So the adenocarcinoma is the most common kind of esophageal cancer in this country. In other countries, the squamous cell carcinoma is more common, because GERD's not as big a problem in other countries. Why is that, I wonder? Okay. Yeah, I have hypotheses about that. All right, continuing with problems, let's move on down a little bit lower. We're in the stomach now. It's this strong, hollow, muscular organ. Its job is to mash things up. Secretions come from these gastric pits. We'll see those in more detail in a moment. What do I want to tell you about this? Oh, here it is. So we have the secretions by the parietal cells, as we've mentioned, that drops the stomach pH. And let me remind you, dropping pH means more acidic. Drop acid. It can be as low as 2. So this activates. So there's something called pepsinogen. It's a precursor to this protease called this enzyme pepsin. So once the stomach pH is low enough, that'll activate this thing called pepsin, and it will, the pepsin can start digesting some of the proteins. That very low pH also can digest some bacteria. There is one famous bacterium that can survive it, and we'll talk about that one separately. But most bacteria are done away at this very low pH. And as I've mentioned, you make the pepsinogen, which is the pepsin precursor, you make mucus, and the hormone gastrin. Gastrin was the signal to make hydrochloric acid, to make more hydrochloric acid and make intrinsic factor and release those. All right, some more gastric glands and gastric pits. All right, so we're looking at the surface, the inside surface of the stomach. There's lots of pits down here. Gastric pits, what do I want to point out to you? The parietal cells, these are the ones that were making hydrochloric acid and making intrinsic factor. Oh, here we go. Parietal cells, hydrochloric acid and intrinsic factor. Then we have the peptic cells. They make pepsinogen. That's the thing that's going to get activated to pepsin. And then mucus cells. And they make a bicarbonate-rich mucus. And you might say, wait a minute, wouldn't that neutralize the acid? Well, kinda. And you kind of want that because you want that mucus right on the surface of the stomach cells themselves. And that's how the stomach cells are protected from this very low pH. Nobody can really tolerate this very low pH. And so we have to have mechanisms to kind of try to protect the stomach. So you're not pumping huge amounts of bicarbonate into the lumen. You're just making this very basic, I don't know, I think of it as like a salve, you know, that you're going to smear on the inside of the cells, or the inside of the stomach on the cells that are lining the stomach, to keep the acid from touching them. Now we're going to look at this in some detail. We're looking at a parietal cell. This is a parietal cell. It has the potential to secrete hydrochloric acid, and it does that by pumping hydrogen ions, also known as protons, pumping those across the cell membrane at the same time that chloride ions are coming out a different hole, and voila, you have hydrochloric acid. So there is, that pump is called a hydrogen potassium ATPase, also known as a proton pump. Whenever I highlight things in yellow, other than the page numbers, the highlighting in yellow, I try to be consistent. This is when I'm referring to a medication. And so this is where proton pump inhibitors act, things like omeprazole, for example. They block that proton pump, so they inhibit the pumping of all this acid out into the stomach. Now, there's a couple of other medications that can also be used here, but you have to understand a little bit, a few other things to understand this. So another way of getting how to say this, the proton pump activity is modulated. It can be made to go more, to stimulate it, and it can be inhibited. And the stimulation comes from acetylcholine, that's parasympathetic nervous system stimulation, the hormone gastrin, we've mentioned this before, and check it out, histamine. Wait a minute, we talked about histamine before, we talked about it with mast cells. What on earth does it have to do here? Well, histamine here stimulates acid secretion. So there are receptors. Let me see if I can find it quick. Okay, here, there's a histamine receptor. So when histamine binds here, it causes more stimulation to make more acid. That's another place for an inhibitor. So the histamine, the H2 receptor antagonists, this is where they act. They say, don't stimulate the pump, don't stimulate the proton pump. And these are medications like famotidine. All right, so both of these act to make less acid. We'll have to come back to this, but prostaglandins, which we've also talked about before, prostaglandins inhibit acid secretion. So here's a prostaglandin, there's a receptor for it, and it says, you can't see this very well, but there's a negative sign here. It basically says, don't make a lot of acid. So prostaglandins work against making acid. They are protective of the stomach, and we'll get back to that. All right, so stomach protection from gastric acid, as we've said, we've got some cells that are making this very bicarbonate-rich mucus. That mucus layer closely lines the stomach, and then the gastric acid, you still have to make it, but it shoots out like a little jet through the mucus layer. And so it remains on the lumen side, so most of that acid is actually not touching our own stomach cells. And then prostaglandins, as I've mentioned, they reduce the acid secretion, so they inhibit that proton pump. They increase this very basic mucus. I'm not going to go through the details there, but here's what I want to get to, and that is when patients take medications that block prostaglandin production, and why they would ever take medications like this. We're talking about NSAIDs, the non-steroidal anti-inflammatory drugs. They're great. They're great for pain relief because remember, prostaglandins are the things that stimulate our pain receptors and say something hurts. And so we cleverly say, I'm going to take an NSAID, so I'm going to decrease the production of these prostaglandins so I don't feel that pain. The downside is if somebody's taking NSAIDs chronically, they're taking it all the time, every day, all day, every day, they're reducing the amount of mucus that they're making to line the stomach. And that's why NSAIDs are associated with the production or the development of peptic ulcers. It's not the intention, we don't want it to have an impact on the stomach. And this is true even if the person is taking an NSAID topically. They don't even have to be taking it in through their mouth. They can be absorbing it through their skin. It's still going to inhibit prostaglandins, and it's still going to have this impact on the gastrointestinal tract. All right, so that brings us to peptic ulcers. So the most common sites for peptic ulcers are the duodenum and the stomach. Well, the stomach, of course, but duodenum. So think stomach, and then a little bit below the stomach, the duodenum, the very first bit of the small intestine, and then go up a little bit from the stomach, and that's the esophagus. Those are the places where you're likely to see peptic ulcers, and it's mostly in the stomach and the duodenum. The increased risk of peptic ulcers with hyperacidity. Smoking will do this because it reduces the gastric mucosal blood flow, so you're not going to make as much mucus. Reflux, NSAIDs, as I've already said. Here's a really important one. Most bacteria are toast in the stomach, with one notable exception. There's a bacterium called Helicobacter pylori, or just H. pylori. Oh my gosh, these things are so clever. They have this mechanism where they can burrow into the mucus, that very basic mucus that we have in our stomachs, and they kind of protect themselves that way. They also, it doesn't matter. They have mechanisms that protect themselves from stomach acid. That infection is the explanation for most of the peptic ulcers that we see, or many of the peptic ulcers that we see. So it leads to chronic gastric inflammation. This increases the risk of developing stomach cancer. So when somebody has peptic ulcer disease, we have to manage the GERD. Well, if they have a H. pylori infection, you absolutely have to get rid of the H. pylori infection. That means being on antibiotics for an extended period and being on acid reducers for an extended period. So we use histamine H2 blocking drugs, the proton pump inhibitors, as we've said, and short-term antacids to just neutralize the acid in the stomach. We're talking about Tums, things like that. A different problem with the stomach is known as gastroparesis, so paralysis of the stomach. It's reduced motility, and what leads to it is there's an alteration in the nervous system stimulation. One of the things that causes this, and we haven't talked about diabetes very much yet. We've mentioned it in passing. But we'll talk about it in more detail at the end of the semester. basically the high blood sugar is really damaging to capillaries. It's really damaging to the blood supply. It's really damaging to the blood supply to the neurons. And so the nerves that are supposed to be stimulating the stomach to move things along after eating, those neurons aren't working as well as they're supposed to because of the excess blood sugar. The problem, one of the biggest problems, if this is due to the diabetes, is the patients who have this problem are often dependent on insulin. And so you know you have to coordinate the intake of the food with the injection of the insulin to hopefully match the rise of the blood glucose with the, the activity of the insulin and keep the blood sugar normal. Oh my gosh. So you take the insulin, the patient eats the food, the insulin's still going to do its job, but the food's just sitting in the stomach. And so we have these huge crashes in blood sugar because it's really hard to coordinate the insulin with the food intake because this isn't predictable. Like when the stomach is finally going to move things along, we don't know. And so this just, it complicates the care of diabetic patients even more than it's already complicated. And then sometimes we don't know why this happens. And for some people, it's after surgery that it happens. But anyway, if there's insulin involved, this just increases the complexity of caring for this patient. Small intestine structures facilitate absorption. I'm going to look forward a second. Yep, okay, a few more slides. All right, so I've already mentioned there's a lot of surface area in the small intestines. The villi are these larger multicellular structures. They've got their own blood supply in them. And then what we call microvilli, if you zoom in on one of the individual cells, you've got these like ridges on the cells themselves. Those are the so-called microvilli. And all together, they're sometimes referred to as brush border because it looks like a brush. It's got multiple bristles. It just increases the surface area that's available to contact the chyme. I haven't used this word before, maybe I've used it. It's the mixture of stuff that comes from the stomach. And so the more surface area you have, the more likely you are to be able to absorb nutrients from there. Speaking of nutrients, we'll talk about digestion of the macromolecules, but I'll mention here because, yeah, I'll mention here. So you remember carbohydrates get broken down. They're polysaccharides. They get broken down to the individual monosaccharides, mostly glucose. And proteins get broken down to their subunits, which are amino acids. Interestingly, just like in the kidney, remember we had the sodium-potassium pump that all the cells have, and they create that gradient where you have more sodium on the outside and less on the inside, and sodium is welcomed back into the cell. And then in the proximal convoluted tubule, we used that. Sodium could come in, but it would bring along a glucose or it would bring along an amino acid. Oh my goodness, exactly the same setup here. This is that nightclub situation. So on the one side of the cell, this is intestinal epithelial cell, we've got the regular sodium-potassium pump. That's all the cells have that. But then on the apical side, this is the side that's in contact with the food. That's where we have the secondary active transport. So the sodium is being welcomed back in, and it's bringing along, here's the sodium being welcomed back in, and it's bringing along a glucose. Or in a different transporter, here's the sodium being welcomed back in, and it's bringing along an amino acid with it. So fantastic. Okay, the other point I want to make here is about oral drugs. This is how you take in medications. So a few different things can happen with oral medications. They could, if you're lucky, you take them in, they get absorbed, and they get through both sides of the membrane, and nothing's changed. They just come in unchanged. Or you absorb the drug, it comes in, and then it passes through, it gets metabolized somehow, and what you absorb into the bloodstream is some metabolized form of the drug. the drug gets in and then it's kicked right back out. And that is not something that the pharmacological activity is happy about. You want to be able to get the drug across and into the person's bloodstream, but it doesn't always work easily. Okay, and then this is the last slide in this section. We can have malabsorption issues. There can be a problem with taking stuff in the way it's supposed to be brought in. And we'll talk about two of them on this slide. One I alluded to in the review video, and that is lactose intolerance. I'll remind you, lactose is a sugar, a disaccharide. It's got two sugars hooked together, one of which is a galactose and the other one might be a glucose or a fructose, I can't remember, but it doesn't matter. It's two monosaccharides hooked together. The deal is all of us as infants have an enzyme called lactase, and its job is to break apart these two sugars from each other. And as infants, every human being, we've got this. I shouldn't say every, most human beings have this. Some of us retain that lactase activity after childhood, and some of us don't. And those of us who don't retain that activity are known as lactose intolerant. And so you can consume the dairy product that has the lactose in it, but lacking this enzyme lactase, we don't have the ability to break those two sugars apart. And we also don't have the ability to absorb this two sugar unit. We can't bring it across the cell. It can't come in through the brush border. And so that lactose remains in the lumen. If you know this, sugars are very attractive to water. So the water remains in the lumen, and that leads to the so-called osmotic diarrhea. Because we have this undigested sugar and it's just staying in the lumen, we are feeding the microbes further along in the digestive tract. They produce gases. That's where the bloating comes from. And so, yeah, so this malabsorption problem can lead to this osmotic diarrhea problem. Separate issue, but also related to malabsorption, is vitamin B12 deficiency. And we've addressed this before when we were talking about red blood cell production. The absorption of vitamin B12 absolutely depends on the production of intrinsic factor in the stomach. The parietal cells of the stomach have to make intrinsic factor, and somewhere between the stomach and the ileum, the B12 and intrinsic factor need to bind to each other so that in the ileum, that complex can be brought in, can be brought across this brush border and into the cells. And so a B12 deficiency can result from a malabsorption, either because we're missing the receptors, in fact, we may be missing a whole section of small intestine because of surgery, surgical resection due to cancer or some other reason, or there's not enough intrinsic factor being made, either because of gastrectomy or because of an autoimmune problem. The point is there's no intrinsic factor. So even though the person may be consuming B12, they can't absorb it. And that leads to the B12 deficiency. And this needs to be remedied, usually with injections of B12. And that is the end of this section of the lecture. See you in part 3.